Sir, shall we start, sir? So, good morning, one and all present here. So, a warm welcome to the every participants to the webinar, which is conducted by IPEL. So, IPEL is nothing but Interactive Physio e-learning, where we are providing free online webinars, online classes, clinical presentation, journal presentation, and hands-on workshop for physios. And I need to add few words about IPL. So, which is founded by Dr. Professor Sandosh Raja sir, MPT Orthopedics, who is a professor in Swami Vivekananda College of Physiotherapy on 15 to 2023. So, today again, I would like to welcome Dr. Professor Sandosh Raja sir, Managing Director of IPEL. Welcome, sir. And I would like to welcome today's speaker, Dr. Ashwini, MPT Neuro PhD, HOD Department of Physiotherapy, Avinashi Lingam Institute for Home Sciences, Higher Education for Women and Coimbatore. Behalf of IPEL, I welcome you, ma'am.
Thank you.
Today, our topic is about basic anatomy and clinical view of texting neck syndrome. So I would like to give a few instructions to the participants. So kindly unmute your microphone as well as your video. So after Ashwini madam's session, we will be having a question answer session where participants can clear your doubts. And myself, Fernandez Franklin, CAO, IPEL. Thank you. Welcome, ma'am. You can start.
Happy morning, one and all presence here. It's audible?
Yes, ma'am, it is audible. Kindly share your screen, please.
Okay. So first, I will like to thank Dr. And Professor Sandosh Raja sir and my dear friend Franklin. Thank you for this opportunity. Let's move into the session.
Ma'am, kindly share your screen, please.
It's visible. It's visible.
I am not able to see the screen. Any of the participants kindly respond to the comment, please.
Yes, ma'am, it's visible.
Okay, ma'am, continue, please.
So today our topic is Text-Neck syndrome. We all know about this is a recent epidemic disorders. So it's in the word Text-Neck syndrome, first of all coined by Dr. D.L. Fishman in 2018. Nowadays is a booming ergonomic disorders. The repeated stress injuries and the pain in the neck and the shoulder area resulting excessive watching of handheld device, not only the cell phone and mobile phones, it's using laptops and other handheld devices also. It's creating pressure on the neck, that the syndrome name is Text-Neck. Otherwise, it's called as turtleneck posture and also the anterior head syndrome. It's somewhat related to the upper cross syndrome also. So, participant, any doubt, you can clarify it any time. And also, it's an interactive session only. So in this research studies, Text-Neck has become affected millions of people in the all age group. It's commonly recent studies shows that the age group of 25 to 35, it's affected more, and the female is more affected. So randomly, 62.3% of users experience of neck pain and the shoulder region while using the smartphone. So commonly in the upper neck positions and the trapezius region, and the sometimes it's pain radiating towards the upper limb also. So, first of all, we see what are the basic anatomical structures present in the cervical region, neck. So, first we see the bones. It has seven cranial bones and cervical bones. So, first bone is atlas and second bone is axis. It's internally connected within the facet joint, and also it has a small spinous process. It's interconnected within the vertebral body with vertebral disc also. So this is the structures passed through the cervical canal. The vertebral body and disc, vertebral artery and nerve roots also. So, and the intervertebral disc also plays a major role to transfer the weight from head to other spinal cord also. It's connected to two main ligaments, anterior longitudinal ligament and the posterior longitudinal spinal ligament, and interspinal ligament also, and intertransverse ligament. These are the major ligament structures surrounded the cervical vertebrae. So next we move into the muscle. So in the neck muscle, and the neck surrounded the neck, it's divided into the three views. One is anterior, lateral, and the posterior view. The anterior view further it's classified into the superior, and based on the hyoid bone, it's separated by suprahyoid bone and the infrahyoid bone and the anterior vertebral bone. So one by one we see the muscle. So anterior view of neck muscles majorly divided into four types. One is superficial, suprahyoid, infrahyoid, and the anterior vertebral muscle. This is the suprahyoid muscle. First one is platysma. So platysma is a generalized muscle. So below the subcutaneous tissues, the platysma is present. So major action of this platysma is facial expression and 50% of neck movements. The next major muscle is sternocleidomastoid. You see in the picture it has two heads, right? It's visible. It's visible.
Yes, ma'am. You can continue.
It has two head. One is it attaches to the manubrium sterni. Another one is it attaches to the sternal medial end of clavicle also. The action of the sternocleidomastoid, it has two separate action. One is unilateral contraction and another one is bilateral contraction. So when the sternocleidomastoid is unilaterally contracted, it presenting lateral flexion and contralateral head rotation. So unilateral flexion and contralateral head rotation, and the bilateral contraction is presenting head vertical flexion. So forward head flexion is done by sternocleidomastoid bilateral flexion. So next is another layer of superficial. It's separated by the based on the hyoid bone. It's divided into suprahyoid and the infrahyoid muscle. The suprahyoid muscle it comprises of four muscles. One is digastric and mylohyoid, genohyoid, and the stylohyoid. In this all four group of hyoid muscles, the common function is while vocalization and swallowing, it's stabilizing the hyoid bone to move, and the mandible also move in the synchronized manner. And the position of hyoid bone and the mandible depression, it's maintained by suprahyoid muscle. And another structure is infrahyoid muscle. This also comprising four muscles. One is sternohyoid. The name itself it's connected to the hyoid and the sternum. And the sternothyroid, it's connected to the thyroid cartilage and the sternum. And thyrohyoid, it's connected to the thyroid and the hyoid bone. And the homohyoid, it's connected to the hyoid and the lateral superior border of scapula. So these are the infrahyoid muscles help into the thyroid cartilage and the hyoid bone, make it a stabilized manner while vocalization and swallowing also. So this is mild participation in the forward flexion. During the forward flexion to stabilize the thyroid cartilage and the hyoid bone. Next is anterior view in the anterior vertebral muscle. It comprises of three muscle. One is rectus capitalis and longus capitalis and the longus colic muscle. These are the muscles. Common function is while forward vertical head flexion to stabilize the vertebral body in the stable position, as well as mild range of motions presence in the anterior vertebral body. These are the anterior view muscle. So far anteriorly we have 4 layers of muscle. One is superior and the suprahyoid muscle group and the infrahyoid muscle group and the anterior vertebral muscle group. Now move into the lateral view of muscles. The lateral vertebral muscles of neck is commonly it's called as scalenary muscle. It has divided into 3 muscles comprise. One is anterior scalenary, middle scalenary, and the posterior scalenary. These scalenary muscles common function is, so while vocalization and the swallowing, it's placed in the position particularly in the ipsilateral flexion. So it's helping to ipsilateral flexion and the ipsilateral head rotation. It's helping to the ipsilateral head flexion. So lateral flexion helped by the scalenary muscle. The anterior angle flexion is mainly worked by anterior scalenary, and the middle, exactly lateral coronal axis flexion is done by middle scalenary, and the posterior view of lateral flexion is done by posterior scalenary muscle. So next move into the posterior view of neck muscles. So posteriorly we have, again it's divided into the 3 layer. One is superficial layer and deep layer and the deepest layer. So initially the posterior view superficial layer is comprises of 3 muscles. One is trapezius, we all know about. It has 3 separate fibers running through occipital protuberance to thoracic vertebra. It has 3 fibers. One is upper fibers and middle fibers and lower fibers. Upper fibers is running descends towards the scapula, and the middle fibers horizontally running towards the scapula, and the lower fibers it's ascending towards the vertebra to scapula. The trapezius is a major upper back muscle that producing extension and lateral flexion and rotation also. So in the another superficial muscle is splenius capitis and splenius cervicalis. This also play a role in extension activity of neck, and so also it's stabilizing the splenius occipital protuberance and the vertebral body to act throughout the head extension. Next is deep layer. So deep layer, it consists of cervical transversus spinalis muscle. It also comprises of 2 muscles. One is semispinalis capitis and semispinalis cervix. So capitis means it's the muscle attaches to the occipital protuberance, so it's called as capitis. So spinous process to capitis, and semispinalis cervix, it attaches to spinous process through on the cervical bone, cervical 3 to cervical 7. It's called as semispinalis cervicus. This deep layer muscles also help to head extension and also the contralateral head rotation. So another deepest layer is suboccipital muscle. It comprises of 2 muscle. One is rectus capitis posterior major and minor. Another one is oblique capitis superior and the inferior. In this picture, you see the green color is rectus capitis posterior major. It's help to terminal neck extension. It's done by deepest layer, and the obliquus capitis superior and the inferior is also contralateral rotation and the ipsilateral rotation is take place while extending the neck. So these are the basic anatomical view of neck and the muscular structures in the neck around the region. In the Tex-Neck syndrome, not only affected the neck muscle, it's also affected the upper back muscles. The major muscles are subscapular muscles, levator scapulae, and rhomboides. Because rhomboides is a stabilizer muscle for the head movement. One movement is completed, it has comprises of 3 movers. One is primary mover, secondary mover, and the another major muscle is stabilizer muscle. While doing neck rotation activities, the rhomboides major and minor act as a stabilizer muscle. When it has some trigger point in the rhomboides muscle, that can also be producing the restricted movement of head rotations also. So not only affected in the neck muscle, it's also affected in the upper back muscle, mainly in levator scapulae and rhomboides major and minor and supraspinatus also. These are the muscles commonly get triggered in the Tex-Neck syndrome. So next move into biomechanical changes take place in cervical vertebra and also the muscle. We'll see. So any doubt in so far anatomical view? The muscles, muscular structure and the vertebra. Any doubts?
No, ma'am.
Okay. So shall we move into the biomechanical changes? What are the changes take place in cervical vertebra as well as muscular structure? Simply, the human head is heavy than the normal structures. Weight between 4 to 5 kg. The neural position is the top of your neck. With the weight is supported by the surrounding muscle, tendons, and the ligaments. So the head weight transfers to the trunk through the neck structure only. It's supported by the surrounding muscles, tendons, and the ligament. The flexion your head forward and downward while using handheld device like cell phones and laptops, whatever handheld device, it producing the triple the weight of head force that transfers into the muscle through the neck. It's the muscle producing force to keep the neck in the neutral position. It's in the longer period of time. That's for example, texting and reading and studying. It's producing longer period of time. It's producing a stress and the pressure over the soft tissues around the cervical spine. This injury is believed to be caused by bad posture associated with too much texting and overusing of handheld device. So think hanging over your smartphone and tablets for the hour, dropping your head forward to changing the neural curvature to your fight. So normally have a mild lordosis and curvature. While using the handheld device, it has degree of neck flexion that creating the weight force generated in your neck muscles. In 30 degree of neck flexion, while using handheld device more than 1 hour, that creating 80 kgs of weight pressure transfers your neck muscles as well as tendons and the ligaments also. While 45 degree of neck flexion, that creating 24 kgs of weight transfers your neck, and 70 degree of neck flexion. Moreover, more than 60 degree of neck flexion, that creating 28 kg force transfers your neck. The neck muscle against the gravity, it's pulled to the neck into the neutral position, that creating strain on your neck structure, soft tissues, and the ligament structures also. So in the cervical spine, generally it's a C-shaped curvature. If your head drift forward and downward to your device, the lower cervical spine connected to your shoulder and the upper goes into the hyperflexion, flattening of natural curvature of cervical spine. Did you see in the flexure picture? It has hyper extension in the upper cervical spine and hyperflexion in lower cervical. So normally it's C-shaped curvature. While using handheld device more than the time, that's creating biomechanical changes take place in the anatomical C-shaped curvature also. So upper cervical spine is hyper extended and the lower cervical spine is hyperflexion, that creating pressure on intervertebral disc as well as the surrounding muscle, and major structure get comprised in the severe stages is neural nerve will be compressed. Mainly the cervical nerve compression will be take place. This is put extra pressure on the intervertebral disc, vertebra, connecting facet joint, which can exacerbation of spinal degeneration, which also causes your spinal canal lengthening through the neck, increase the tension of spinal cord and the nerve compression. So initially, the hyperextension, hyperflexion take place in the cervical spine adjustments. The laterally faces joint degeneration and also intervertebral disc degeneration started, and the nuchal compression will be created laterally. So for this association, increase in the load on the cervical spine, changing in the length and the strength of the cervical muscle. Not only the biomechanical changes take place in vertebral body as well as it take place in the muscular structures also. Because while the posture is changes, the center of gravity is moves from the balance. It's move anteriorly, that creating the pressure on torsion joints, the intervertebral facet joints creating a pressure. By the position of head forward, the distance between sternum and the manubrium become increased, and the result of infra-suprahyoid muscle gets stretched and weakened by pulling back down the mental protuberance. So initially we see about anteriorly we have a suprahyoid and the infrahyoid muscle. It's majorly working as a hyoid bone in the stable position. So with the biochemical changes take place in various spine. While using mobile for more than a hour, that creating pressure on the infra and the suprahyoid muscle. That's also creating the positional changes in the cervical spine. For the composite, the upper thoracic increases the kyphotic curvature and the thoracic spine. That will be resulting rising the lordosis curvature of lumbar vertebra. So initially, so not only take place in the cervical vertebra, followed by its composition action is take place in the thoracic and the lumbar lordosis also. So this is shifted the center of gravity will affect the biomechanical changes in the entire spine as well as slope of pelvis. The posterior compression shorten suboccipital muscle, compression of facet joint, and the posterior longitudinal ligament structure gets stretched, and dysfunction such as irritation, compression of greater occipital nerve and the vertebral artery also. So initial simple changes take place in the vertebral cervical bone that's creating the all surrounding structures and nearby spine, entire spinal cord also it's get biomechanical changes will be take place. Excessive upper cervical extension result in decreased space in atlanto-occipital and atlanto-axial joint that result in increasing compressive force placed posteriorly. So generally, I already classified the muscle groups in the neck, anterior, lateral, and the posterior muscle group. Generally, the muscular imbalance associated within the Tex-Neck syndrome resulting from combined elongation and the weakening of anterior neck muscles. So mainly, I told that sternocleidomastoid, superior hyoid muscle, inferior hyoid muscle, and the anterior vertebral muscle get weakened. So it's vice versa. The contraction and the stiffness is taken by the posterior neck muscle. So major muscle is trapezius and the semispinalis muscle and suboccipital muscle gets shortened, that creating excessive pressure and the muscular imbalance to the other muscles also. So not only the biomechanical changes take place in the cervical region, as well also it's take place associated changes in the scapular muscles and the upper back muscles also, that creating compression on the cervical nerve and also the posture of the cervical spine also. So also associated muscle get elongated and weakness including deep cervical flexor, erector spinae, and the shoulder retractor muscles, mainly rhomboides major and the rhomboides major and levator scapula muscles get weakened. And these muscles may be including strengthen and the relieving the pain by the correlation long-term Tex-Neck syndrome. The muscle becomes shorten and tighten, mainly suboccipital muscle, pectoral muscle, and the levator scapular muscle get tighten and shorten. So anterior muscle get weaken and lengthen, and the posterior muscle group get shorten and tighten, that creating a pressure on facet joint and also the neural structure, that creating numbness also in the upper arms. The posture also involving decreasing the cervical lordosis as well as alteration of the thoracic kyphosis and changing the scapular position, including protraction and downward rotation of the scapula. So it's also association changes take place in the scapula. Scapula is normally normal place to it protracted and downward rotation take place while Tex-Neck syndrome. It's part of due to weakness of rhomboides and the middle trapezius and the tightness of pectoralis majors. It take place in rhomboides and the middle trapezius tightness and the pectoralis minor tightness. The scapular rotation is take place. And the secondary condition commonly seen in the patient with forwarded neck posture, it's known as upper cross syndrome. So lately it's developing by the upper, it's interconnected to the upper cross syndrome. resulting from the ligamentum muscular imbalance and the neck and the upper extremity. In this picture, we see weak of deep neck flexors and tighten of pectoralis major in the anterior view, and the tighten of upper trapezius and the levator scapula, and the weaken of rhomboides and serratus anterior in the posterior view. This is it's shortly related to the upper crust syndrome also. So these are the biomechanical changes comprises of upper crust syndrome, protraction of shoulder, rotation of scapular bones, and the reduction of extensibility of rib cage. So because of scapular protrusion and retraction, the rib cage extension will be reduced in the later stages in the severe form of Tex-Neck syndrome. Excessive load on the facet joint reducing the intervertebral mobility. Anterior cervical compression and the posterior cervical elongation is take place throughout the muscle and also the cervical spine. So any doubt in the biomechanical changes take place in the bone and the muscles? Any doubt?
No, ma'am.
Okay. So next move into what are the signs and symptoms present in Tex-Neck syndrome. So common symptoms is stiff neck, pain, muscular spasm, radiating pain, tension type headache, and the vertigo. So in the stiff neck, typically shortness, difficulty when they try to move the head down on the one side. So initially start paining in the trapezius region. It's later on it's developing to the head extension position. It's get a pain and the stiffness. The pain, spot pain in the back and the side of the lower neck, which can be feel dull and the aching pain, and sharp and stabbing pain followed by the severe pain. Initially, it's a dull aching pain followed by repeated strain is creating the sharp and stabbing pain. And the upper back, not only the neck region, it also in the upper back region also, mainly in the trapezius and the rhomboides regions also, it's get pain and the muscle spasm and the radiating pain. So once it's converted into the acute and the chronic stage, the interfacial joint load is excessive. The neural structures, cervical nerve get compressed, that creating radiating pain, travel into the shoulder and the arms, and tension type headache. Initially, the trapezius, levator, rhomboides trigger point that creating the tension type headache. So in differential diagnostic, in type of headaches also produced by the trapezius muscle strain, and the vertigo like symptoms also presents in the later stage. The some other symptoms including condition becomes severe. These are the initial symptoms and acute to subacute stage. The symptoms is severe in the severe form of Tex-Neck syndrome, flattening of thoracic kyphosis, decreased shoulder range of motion, early onset of arthritis, cervical spondylosis is started, spinal degeneration, disc compression, muscle weakness and tightness, loss of lung capacity, and the vision problem also. Sometimes it's a vertebral artery insufficiency that creating some systemic symptoms also will be produced. So next move into assessment for these are the anatomical view, what are the biomechanical changes, what are the signs and symptoms in the Tex-Neck syndrome. Next move into the assessment part, how to assess the what are the epidemiological view in the Tex-Neck syndrome. Generally, the female is more affected in the based on the research studies because of the anatomical posture. And the age is 20 to 40 years is common. Occupation is cooperative sector, students and IT workers, prolonged handheld device users. Chief complaints, neck pain, stiffness with or without radiating pain. Initially, neck pain and stiffness. Laterly, it's associated with the radiating pain and also the headache also. And the observation, so neck and head anterior to the body is normal alignment, protraction of the shoulder, scapula is protracted and the protracted shoulder will be present. Abnormal spinal curvature, flattening of cervical, hyperlordosis of cervical spine, hyperkyphosis of thoracics. And the gait cycle, arm swing little bit decreases in the severe form of stage. And palpation, paracervical muscle spasm, tenderness, and trigger point mainly in the trapezius, levator, rhomboides, and the scalene muscle also. Sometimes the scalene trigger points also that creating radiating pain in the arm and the shoulder. On examination, A range of motion, active and the passive range of motion restricted due to pain, and the shoulder pain-free and full range of motion will not be achieved, and the neural calcification will be present. Pain examination, onset, gradual onset in the acute pain, dull aching pain, and the severe form of pain, it's sharp shooting pain. Location, neck, shoulder, and upper back region. Nature of pain is intermittent. So not in the continuous pain, sometimes it's intermittent, radiating towards the arm and the hand. Aggressive factors, forward head task, it's been aggressive more than a time. The relieving factor is rest and the medications. So functional assessment, neck disability index, and smartphone additional scale. So what are the differential diagnosis presence in chest neck syndrome is cervical radiculopathy, cervical spondylosis, ankylosis spondylitis, neck strain, and cervical PIVD, and facet arthropathies. These are the differential diagnosis in chest neck syndrome. So for any doubts? Any doubts in anatomy?
No, ma'am. No, ma'am.
And differential diagnosis? So next, move into the treatment goal. Main goal is to reduce the pain and increase in the range of motion. The reduce the spasm and stiffness, and reduce the functional limitation, increase the muscle strength, and correction by the biomechanical changes, and reduce the inflammation, and the relieving the neurological compression if it's existed. So generally, pain management by modality and the exercise therapy. So exercise therapy mainly focusing on first we analyze what are the muscle get weak and what are the muscle get tighten. So I initially told that the anterior compartment muscle get weaker. So focusing on the sternocleidomastoid and the hyoid muscles, strengthening will be started, and the stretching of pectoral muscle and the trapezius and the levator muscle get stretched, and rhomboids also get. Sometimes it's mixed in the state. Sometimes it's get weaker. Sometimes some patients it's get tighter. So focusing on the muscle power based on the exercise will be prescribed. The initial pain management by modalities like ultrasound, TENS, ice packs, and the hydrocollateral packs. Laterly, it cured by only exercise therapy, strengthening and stretching muscles, and also be the ergonomic advice. So what are the strengthening exercise will be given for chest neck syndrome is scapular stabilizer exercise, and shoulder strengthening, cervical stabilization, chin tucking, and the stretching including the pectoralis muscle, sternocleidomastoid, and levator scapulae, and scalenate, trapezius, scapular retractor, form rolling exercise will be given for the stretching. These are the structure get tightened muscle. So trigger points mainly in the trapezius and the occipital muscles. This trigger points that creating the one side. It's like tension induced headache type. So some patient is come with upper trapezius region pain as well as the headache. Once you releasing the trigger points in the trapezius, the headache will be released, and some taping technique also used for this trapezius muscle strain. Why it's mainly focusing on why this muscle mainly trapezius get weaker, tighten means sometimes it's a co-associated action only. So deltoid muscle weakness also that creating excessive pressure on the trapezius muscle, that's also creating the secondary chest neck syndrome. So once any surrounding muscle get weaker, the normal muscle get overacted at strain easily. So deltoid muscle weakness also that creating excessive pressure on the trapezius muscle, that creating trigger points also in the trapezius muscle. The postural correction and the ergonomic advice and being given. These are the ergonomic advice will given for the chest neck syndrome. While using computer also in the proper position, while using handheld device also it's been the proper position. So hand and the elbow position and the back position with support, this also been maintained to prevent chest neck syndrome. These are the home advice: hot water fermentation, isometric self stretching exercise, and range of motion exercise. And patient to control the handheld device user in between every 10 minutes or 20 minutes, once it get break and rest, then only we move to the jobs or anything. These are the prevention. So hold your mobile device or handheld device in the high level, slide chin tucking exercise and roll the shoulder blade backwards. These are the simple exercises will be while using the mobile phone or laptops in the longer period. Take a break your mobile device every 15 minutes. Set the reminder, shift the position and ergonomic care. These are the home prevention for the text neck syndrome. That's all about text neck syndrome. Any doubt in this?
No, ma'am.
No, ma'am. No, ma'am.
Now it's for the question answer session. So participants can interact with the speaker. So you can have your doubts.
Any doubts related to muscle and treatment approaches? Any differential diagnosis? Anything?
Participants can interact with the speaker. Kindly make use of the question answer session, please.
So someone is asking hump neck is associated with the text neck syndrome. So not purely hump neck. It has different two types. One is excessive use of handheld device and the text neck syndrome started. Laterly, it's creating as a hump neck due to biomechanical changes in the cervical and the muscular structure. Yes, other hump neck is from the congenital hump necks also present, is that not associated with the text neck, but the text neck syndrome that creating the hump neck, the postural instability will be created in the severe form of text neck syndrome. Any other
Thank you,
doubts?
ma'am. Thank you, ma'am. Any other doubts, participants? Kindly raise your questions, please.
So Australia, I sent the PPT slides. Any other doubts?
Hi, good morning, Ashwini.
Good morning.
It was a very good class. Appreciated that. A lot of insights. And I just like want to know about initial acute phase of line of treatment. So you mentioned about the electro devices and modalities and
Yes.
like
So
the
initially, according to the patient condition, the pain will be segregated in the acute stage. So initially, pain started in the trapezius region, but problem in the anterior neck muscles also. The pain started in the trapezius region and the in the lower occipital region. Initial pain treatments will modalities like ultrasound and initially trigger point release and strengthening exercise also that reducing the pain and followed by the patient, it's continued by the home ergonomic advice in the initial treatments.
so ideally how long we have to wait? Like we have to draw a benchmark of pain score or like
Yes,
what
yes.
is the
Initially,
line?
we done by two scale. One is due to the in the measurement of pain, is VAS will be used, visual analog scale, and the numerical pain rating scale will be used to patient segregated in the acute pain. And neck disability index score also help to what are the disability structures and what are the day-to-day activities the patient get pain worsen, the neck disability index score. Based on the score, we'll give you the treatment. After pre-test and the post-test will be done. Any other doubts?
How long the exercise should be followed and how much time in a day and frequency?
So
You
initially,
concentrating on the upper cross syndrome or like any particular muscle group?
the most of I done a project on text neck syndrome. Initially, patients come with mostly elevator scapula and the rhomboides muscle strain and the trapezius pain initially. So later in the acute form of stage, also patient will be coming for us. The laterally will creating the hump neck and the upper cross syndrome. So initially, the pain only in the trapezius, not any postural abnormalities will take place. The patient it's come more than 3 months and more than 6 months of pain will come with postural abnormalities also. So will initially the acute pain, the patient strengthening and the patient's exercise will be in around 10 to 15 days. Pre-test will be taken as well as also post-test also being taken. In the treatment period is 7 to 10 days in the acute phase.
Thank you, Ashwin.
Thank you.
Any other participants? Please make use of the question answer session. And that was a okay, ma'am. Shall we conclude today's session?
Okay. So
Thank you, ma'am.
thank you.
Thank you for your precious time interacting with the participants. Anyhow, the presentation was very nice, and someone was asking about the repeating space and all. If possible, kind here, ma'am.
Actually, thank you so much for this opportunity, Dr. Santosh Raja sir, and my dear friend and supported in various activities, Dr. Fernandez Franklin sir, and also my friend Karthikeyan is raising the question. The session is more interested to me also. Thank you. Thank you.
So, once again, I would like to thank all participants, Dr. Santosh Raja sir, MDE, who creating this IPEL platform. So, I once again want to thank Dr. Santosh Raja sir.
Thank you.